The future of healthcare innovation begins with powerful conversations. JV EdTech Medivation, in collaboration with Power of Knowing Forum, proudly announces a healthcare podcast series focused on the future of healthcare innovation. This next-generation podcast series explores hospital systems, medical technology, AI in healthcare, and innovation, bringing together experience, expertise, and meaningful dialogue. The series delivers real-world, actionable insights from global healthcare leaders, moving beyond theory toward practical implementation and impact. Beyond theory, this podcast series focuses on real impact by bringing actionable insights from global healthcare leaders, doctors, and technology innovators. The conversations cover key areas such as AI in healthcare, telemedicine, smart hospitals, and emerging medical technologies that are shaping the future of healthcare systems worldwide. Medical schools, healthcare institutions, students, faculty, doctors, and healthcare professionals from India and across the world are invited to be part of this journey. Backed by Power of Knowing Forum's 300-plus episode legacy and aligned with global standards, the series offers structured, easy-to-understand learning for both executives and learners. Our shared vision: make healthcare knowledge accessible, innovative, and impactful. Encourage global collaboration in healthcare education and technology. Empower the next generation to listen.
A very good evening and a warm welcome to everyone. Today we are at the episode 11 MedTech Insight podcast in collaborations with JV EdTech and the Power of Knowing Forum. It's indeed a pleasure for me to welcome each one of you. I'm your host and the podcast moderator, Dr. Jyoti Rao. Today we will talk about a golden hour inside a mind of an emergency doctor, from life-threatening crisis to recovery. It's my privilege to introduce one of the eminent speaker, Dr. Mahesh Mailarappa, who has more than 16 to 18 years of experience with emergency medicines, critical care, and he has been a consultant at the emergency Manipal Hebal Hospital. He also holds a cluster head medical services at Manipal Hospital, Elanka, Hebal, Dodaballapur. His international training exposure include the George Washington University, USA, and the Royal College Emergency Medicine, UK. He is one of the topmost emergency expert we have today. We welcome Dr. Mahesh.
Yeah, good evening. Thank you. And it's a pleasure to be here and to share my thoughts on the emergency medicine and a lot of a discussion that can go across. Thank you so much for having me.
Thank you so much, Doctor. It's a very, indeed, an interesting topic, I must say. When we talk about what if the difference between life and death was not always a new drug or a sophisticated machine, but a decision made in the last few minutes. Now, if you look at the globally, the emergency conditions accounted more than 27 million deaths in 2019, while WHO estimate effective emergency and the critical care could address half of the death, more than one third of the disability in a low third of the mid income countries. Moving to something very, very important, that today we go beyond the emergency, we go beyond the uncertainty, we explore leadership, AI, resilience, and the definite questions which comes into mind that every second matters. Here we are. The first question goes to you with the managing uncertainty. Doctor, in emergency medicine is a fundamental decision making under the uncertainty. The goal is not to wait, but how does the every information and how do you take this initiative to start your journey? Over to you.
Yeah. So thank you again for this podcast, and I hope we have a very meaningful discussion for all the viewers. And any doubts or any questions are most welcome, or no matter how simple it is. So whenever you look at an emergency department per se, it is a place of utmost chaos. Hour which can be silent suddenly becomes such a rush, and then everybody is running pillar to post. So, what mainly matters here for all the emergency doctors is the mindset, how cool they can be, and how they can showcase their skills in such a busy environment where everybody is in a high tension mood, and the mindset itself is very cluttered. So that is why an emergency medicine specialist per se is always found to have a very right approach in terms of understanding what patient comes in, what all could be possible in that patient, because not everybody could be able to give a right information, because emergency itself says that it can be sudden, it can be unexpected, and it can be very confusing at times, because people say till now he was fine, or she was fine, and we're not able to understand, and they're in a mind block where they won't be able to give you information. So most important is we have a very clear set approach called primary survey approach, where, like how whenever there is a vehicle breakdown, an expert will come and look at the parameters, what could be the immediate reason. Similarly, we have a emergency medicine approach where we look at the primary threats. So more than what it could be in terms of uncertainty, we look the evaluation of the threat and saving the life of the patient. So basically, it would be related to breathing or circulation. So it is very clearly set so that we separate the condition from the routine, and make sure we approach the patient in a very streamlined manner and make the right decision, timely decision, take very key inputs from the patient relatives as per the well set questions that we have, and then we take the approach according to that.
Absolutely, doctor. The key takeaway for this would be in emergency medicines, a speed without a structure is dangerous. That's what you have clearly mentioned. But waiting uncertainty can be even more dangerous if somebody is actually predicting. However, let's move on to the from stabilization to the healthcare gateway. Has an emergency department evolved from being place where patients are simply stabilized to becoming in front door, or do you believe the entire healthcare system has been responsible enough?
Yeah. This we have seen a big shift, a paradigm shift from where initially the emergency departments, what now it's called emergency rooms, was previously known as casualty, where we take the patient, we know the patient is sick, and we used to move to the ICU, and we would not have the right person in the emergency room, not trained in emergency. We would have duty doctors. I would use this very layman terms, duty doctors, and then they would just shift the patient to ICU, and everything would happen out of the emergency room. But now the emergency department is the first point of contact for any patient in need of such emergent care or urgent care, where the emergency physicians are available in the emergency room in many hospitals across the country, and they are trained, they are exposed to emergency care as per the protocols, and they don't just evaluate the patient, they stabilize the patient, they do timely treatment, they do the timely diagnostics, and involve the right kind of consultants who come down to the emergency room hand in hand with the emergency doctors, and try to do a multi-specialty approach. Then this is really rampant in many centers, especially in Manipal. We have a very structured emergency medicine approach where multi-specialty care in the emergency has been a big standardized care, so that the outcomes have been wonderful, especially in cases like stroke, polytrauma, multiple injuries, right, and cardiac issues, or multiple systems involved. So that is how it has evolved, not just a place where it could just be like a traffic control room, to what it has become, a fully fledged multi-functional emergency rooms. So that is a good news for the country, actually.
Yeah, absolutely. Because the emergency departments has increasingly have an intersection of acute illness, chronic, diagnostic, critical care evaluation, surgery, etc. And I'm sure that triage also plays a major role where we segregate the patients and we actually take the patient as per the illness has been involved. When it comes to the allocations and the proper the resources, and of course the patient flow, which does really matters here. I would like to ask when it comes to the international gap. So at the end, after the training internationally, you have been a trained, well trained, persons with the fam and the number of initiatives you have been highly qualified. When you see, do you believe there's the biggest, difference between the advanced emergency care systems in internationals or the Indian healthcare system, or what would be your take on this?
So right now, as we look at the manpower in India in emergency medicine, we are evolving very rapidly, and then we are having a lot of people who are trained abroad and come down to the country and standardizing the care, emergency care. So that is very good news. So basically, there are some points where actually, when we look at the international standards, what we could inculcate. So most the priority stands at making the system excellent than making individual hospitals or individual institutions get excellent in their standardized care. Instead of that, we'll have to make standardization across the systems so that there is a uniformity in the clinical care, creating clinical care pathways, protocols in line with the international guidelines. That is very important. So most importantly, right now, what is evolving even in our country is the pre-hospital care. So a lot of lives can be saved when pre-hospital care is very strong for the country. So which it is in the West. So that is something which we'll have to standardize more, and networks between institutions, especially when there is situations like pandemics or disasters. Networks among hospitals or among institutions is very important. We've seen in the recent COVID time, and then that has to be strengthened furthermore. More than infrastructure, it is the processes, the care pathways, and also training the manpower in line with the international standards is what is the need of the hour. And more importantly, the government has to consider emergency medicine to be recognized as a discipline by itself. Even today, in tier 2, tier 1 cities, emergency medicine, if you tell MD emergency medicine, they'll say, oh, is it still, it is there as a specialty. So that is the thing. So people would know where to go for a stroke or heart attack or a major illness. That is where standardize is required.
Perfectly, because the leap in the Indian emergency medicine is not only come from the better hospitals, but it will definitely come from the better systems approach when we have primary, secondary, or tertiary care in India. Now, let's talk about something, designing for the unexpected. As you know, the hospital probably from Mumbai. I worked in Ambani as an emergency specialist, so I must say that the system and the designing was absolutely amazing. We had a triage, we had also had a specific room, OT, isolation, different rooms for the patients. We had an, Carina ventilators and the art of a state, facilities. I'm talking about 2008. Okay, now let us talk to the tier 1, tier 2, and tier 3. What would be your approach and what would be your suggestion when it comes to how do you design an emergency department, something which you cannot predict? Over to you.
Yeah. Emergency room as a standardization, when you look at hospitals who are accredited with bodies across the country. So that is right now mandate that we have certain mandates that has to be followed in the emergency room for not only the patient safety and right approach to the care, but also to have it a flexible space for any kind of situation. So emergency room is not set only for dire emergencies, or it could be any multiple cases or multiple casualties and things like that. It also could be when there are pandemics, disasters, or we have situations where we call for code yellow, code red. You might be knowing this disaster codes. That time, the entire hospital depends on the emergency, the structure. So the most important thing is it's not just about the number of beds. It's about the process flow that is required to be set in all emergencies, especially when you look at in Manipal hospitals. We have a very streamlined structure in the emergency rooms, right from the point of arrival in the emergency till they go out of the emergency room. Either they get admitted or go to the outpatient ward, or they go to diagnostics or get discharged. So the most important thing in the structuring of emergency is the triaging method. So triaging is very important in right kind of outcomes. You know, the triage coding, color coding mechanism, and then the right kind of patient who needs resuscitation gets addressed immediately. Then the right kind of diagnostics happen. Then the timely treatment and multi-specialty references, and then the further care. So with this kind of process, there should also be flexibility that the beds need to be added additionally, the amount of space between beds to add additional, the surge capacity for ventilators, surge capacity for ambulances when it's required, and also manpower, most importantly. So we practice in Manipal, we practice these codes like code yellow, code red, where multiple cases happen, and then we have the entire hospital consultants, nurses, other manpower take the designated roles in the emergency to tackle the multiple cases and give the high priority for the very sick and then downward. So that is most important to be designed in any emergency, so that they, when there is a situation like that, there is no panic. So in continuation to this, most important thing is practice before the real incidents happen. That's why we have the mock drills. And also there should be separate teams built for various situations. And when it comes to tier 1, tier 2, tier 3, you rightly said tier 3 is much more capable of handling multiple situations. However, the government agencies and also institutions like ours, we are putting in effort to go to the other tier cities, conduct trainings, do the observations in their hospitals, and give them the certain ideas how to set up the emergency room with the not only the beds, like I said, the protocols for resuscitation as per the ACLS, BLS, ATLS, and NALS, PALS. Then having the crash carts, and having the manpower trained in all the resuscitation drills, and also to make sure that they conduct the drills and practice before the real event. So this is the model that we practice.
Yeah, absolutely. Because these are the strategic pillars when we talk about the flexible infrastructures. Absolutely, search protocols, cross-train teams, a rapid response team, rapid triage, as well as a real-time monitoring system. And of course, there is a strong coordination which is required between the ICU, OT, and the diagnostic as well.
Absolutely.
When you even talk about the global injury burden alone illustrate the scale of unpredictability, injuries, and the violence causes about 4.4 million deaths annually worldwide and account nearly 8% of all the death. So definitely resilience is not only the ability to predict every emergency, but it is the ability to absorb the unexpected without collapsing. A very well mentioned, doctor. Moving on to the technology, prognosis, and the human dignity. Just because medicine can prolong life does not always mean it should be. Now, have you ever come across with an aware emergency and the critical care have become literally different? And what has the advanced technology you have always come across with the sustainable approach? And how does that been really impacting on the clinical excellence? Over to you.
Can you repeat that? Sorry.
Yeah. So I'm asking you, when it comes to the emergency and the critical care, how does the advanced technology has been played a different role and the clinical excellence has been, increased?
So technology is kind of going hand in hand with the medical care. Actually, if you look at many people thinking that AI is going to take over, or rather, the technology and advances is going to kind of be the forefront of the medical care. I feel the technology is highly supporting the clinicians or the emergency, especially in right time of care, medical care, the diagnostic timelines. If you look at the technology that we have, especially when I'm talking about Manipal Hospital, Yelahanka, we have the state-of-the-art equipment. If you look at our kind of MRIs we have right now in the market, it would take 7 to 10 minutes to complete an MRI, right? So the clinician will be able to take a call within 10 to 15 minutes with the MRI being read. Either in case of stroke, a patient goes either directly to the operating room, or will go to a cath lab for an intervention procedure, or will be just monitored. So there is a lot of advantage more than any disadvantage in having the utility of technology. It could be in diagnostic, it could be in therapeutic. If you look at the newer technology like Electa for radiation oncology, it does not affect any bit of the normal cells when your radiation is given, and the state of the art cath lab equipment that is come in. There has been so much of advancement that people are actually highly benefited by this, and more so in places where the geography around the institutions and hospitals are well educated about the timely emergency care that is required when there are symptoms. So that is the advantage. Even when it comes to monitoring mechanism, there are remote monitoring technology that is coming, where patient in the bedside or at home has a small device without wire, and can raise the right triggers when there is a deviation in their vitals. So it is a boon than anything else, but it always goes hand in hand with the clinician. It cannot bypass them.
Yeah, absolutely. I would like to go back to COVID, which is something and really important. And I'm sure as an emergency consultant, you might have come across with the number of factors and how the emergency was being treated. So would like to know your experience, and are we really prepared now as an Indian or as a developing countries that, we will be really ready for any kind of outbreak in future?
So I was there in the emergency as the head of ER during COVID, and also nodal officer. So I can tell you very proudly, India handled COVID better. You know, in when you look at globally, though there was so much of panic, there was so much of chaos, and rush to the ER. People really were very scared at that point of time. It was a kind of a very scary eye opener for all of us. The main shortcoming that was were the beds and the oxygen. So post that, many hospitals have done the course corrections that is required. They look at the kind of what do you call the bed capacity surging, or even the oxygen, or even the manpower training and things like that. So I think somewhere it is a good learning, and it is not that COVID again has to come. It can be similar, some medical related illness, or it could be anything else. But then people are, yes, much knowledge. Institutions are geared up. They know how to kind of create beds, how to create manpower, how to get resources, and also there's been a lot of training. So hope nothing like that happens again. But then I think we are much better in terms of handling such situations in future.
Yeah, definitely. Moving on to the leadership across the multiple hospitals. Okay. Obviously, you are working as a cluster head for a Manipal group, and when you handle a specific divisions, or we have a diverse team, we have a high stakes holding environment, and the diverse decision making capacity as well. So, do you find any difficulty, or how do you leverage this clarity during the crisis?
Yeah. So when it comes to our institution, suppose for example, you look at the way Manipal leadership runs by itself. So there is a lot of streamlining. So when you look at somebody handling things on the ground and somebody handling multiple units or multiple manpower, so there has always been a decentralizing. Systems run on policies and protocols. Systems run on a very clear clarity. There have been check mechanisms, multiple audits, multiple trainings, and things like that. So leadership basically is about giving somebody that onus, empowering people, and also trusting. So that has been the key in an institution where a big role is played by people at the ground level, which has been supported by leadership teams. And also that is not just let alone by empowering. There have been review mechanisms to see where plugins have to happen. There have been internal, external audit. A lot of things happen at the institutional level, and make sure the standards of care are in par with the international standards. There has always been continued medical education sessions coming together with a lot of topics being discussed, a lot of workshops, and this is always going to empower the clinical manpower and make sure that all come together as a team when there has been a need for, or when there has been a crisis.
Absolutely, because a great healthcare leader does not create a dependency. They create a capable team. When the leader is not available, definitely they can take a decision out of them.
Absolutely.
Okay, fair enough. So let's talk about something with the predicting emergency. Okay, definitely you might have encountered with more than 16 years of experience. You might have encountered with the neonatal, pediatric, geriatric, stroke, or number of emergency. Do you remember a case which can really have changed your perspective or you have changed your life? And then you might have felt that why have taken emergency? Over to you.
Yeah. So I mean, not just one. When you look at emergency experience of more than 1.5, close to 2 decades, so emergency is something which actually creates a lot of maturity in terms of clinical care. Because we handle all specialties in one room, right? So we do not stick to a certain specialty, and we're not trained in that. So we have to think out of the box many a times. And especially you mentioned could be a neonate, could be a pediatric or an adult or a geriatric. So the only thing common to all that changed our view, our vision about giving better emergency care is the empathy that we have developed over time. Looking at the person who presents to the emergency room through their shoes, right? How they would be feeling and what kind of support. See, we've seen a lot of deaths in the emergency who have brought in death, a wife losing an husband or vice versa, or parents losing the kids and things like that. So the emotional quotient at that time is at its peak. So we are trained extensively, and we are training our team members and having a very strong teams across, to understand what is the mindset not only of the doctor of what this topic is about today, even about the relatives who are at a peak of their emotional disturbance, and what kind of support that we could give is a very very challenging thing that we have learned over time. And for example, we had a case. A young gentleman around maybe 35-year-old brought in cardiac arrest, and I had handled this case. And then the wife was shattered. And then when we resuscitated the young gentleman, and then we got back the pulse. I still remember very clearly in 2017, I told the wife, please feel the pulse. And she was like having goosebumps. So I told her, we have got back the pulse, but there is a lot of things that has to be still done. So please, keep your prayers strong, and we will do our best. So these words go a long way for them. Even if the outcome is good or bad. That man was shifted to cath lab. He had a stenting balloon pump applied. And then he came out, and he told me that he could hear the words when the resuscitation were going on. It was very surprising. He came, he told, he wants to make an article out of it. And then even now they're in touch. But the thing that remains is that she always tells us that the support that she received is unforgettable. So this is how we have groomed ourselves. And it every case is very genuine and unique for us. So we don't say that one case gave us everything. So we keep learning with the go.
Amazing, amazing. When you even talk about the predicting emergencies, I'm sure you know as a part of a woman's safety, you might have encountered a couple of medical legal cases. You might have encountered the sexual abuses or the children, any kind of a trauma which might have been really, you have encountered. I would like to know your insight, and is there anything we can actually share the information to our viewers? Because I believe such cases never comes, but it is really important to know, and it's a
Right.
very sensitive topic too. Thank you.
Yeah, medical legal by itself is a vast topic, and every clinician should have certain amount of interest in understanding what are the medical legal implications of clinical practice. One is that there are subset of patients who can come who fall under the medical legal category. Documentation is very important. The certain communication which is given to the patient needs to be clearly documented. Sometimes we'll have to take audio video. And also it is very important to strengthen the policies of medical legal at the institutional level, so that somebody takes the onus of entire reviewing the cases under the medical legal, the reviewing the documentation, reviewing the outcome of that case, and a lot of other things. So there will be, whenever it comes to medical legal, especially a young person who dies, or like you said, a sexual abuse, or it could be child abuse, or it could be assault cases. There'll be a lot of pressure on the medical caregivers, in terms of registering a medical legal case, or a documentation, or disagreement by the family saying that no, they don't want to go ahead. So but it is important that the management takes up this with the caregivers, the medical practitioners, about the importance of not compromising with medical legal cases, and everything has to go as per the practice and the policy. So that is the bottom line when it comes to medical legal. And yes, there should be sessions in the institutions on medical legal practices. Doubts has to be cleared by the experts, with the clinicians, and also that has to be monitored closely, is what I can tell on a summary.
Yeah, definitely. Because when you talk about the medical legal cases, it is entirely a different topic,
Yes.
different subject, and probably the series of the event which might be encountered. And when it comes to the advocacy, when it comes to even assisting in a different status or different state, when it even comes to primary, secondary, and tertiary care services, what we provide and the patients too. Let's move on to the AI in medicine, emergency medicines, right? So, could artificial intelligence become the next member of an emergency care team, and where a doctor should draw the line? Any insight on this?
Yeah, like I told you earlier, the technology right now, what we have is the artificial intelligence. So there has been it has been an addition to the medical practice, no doubt about it. Especially the lot of tools that has come in, early warning signs tools, which gets calculated based on what we document in the system. Then like I told, remote sensors that has been there as a remote monitoring mechanism, works under AI again, and early recognition of certain conditions based on the input that we feed into the system, right? So that has been widely used by the clinicians. Then based on the investigation tools, faster interpretation of clinical diagnosis based on the investigation, first line investigation reports, and all this leading to a quick clinical decision making, quick interventions, and also predicting certain outcomes, managing the search capacity sometimes, and also helping the administration, the management also in handling a lot of burdens when it comes to the EMR, lot of thing. And of course, AI has been very vital when it comes to analytics, drawing conclusions, analyzing the patterns of cases, where there might be need of plug-in of various support mechanisms in clinical care and things like that. So I feel AI has been useful. It is not going to be AI alone or doctor alone. AI and doctor will be the future with proper utilization. Otherwise, what will happen if it is completely led to the AI, or we say no, doctor is prime and we don't want AI. Otherwise, it could be harmful. So, right utilization, the administration looking at the appropriate implementation at the certain levels where AI is required, and monitoring is very important. The only thing is what we have to be careful is that there could be some errors with AI if not monitored, supervised. There are some things called fatigue, system fatigue, or alert fatigue when it comes to AI. That is one of the key terms that is coming up. And then there might be some privacy issues when it comes to AI, and also a lot of data presently. So these are some key things to be wary about.
Yeah, I strongly believe because I'm a research scholar from Geneva, and my research was into the global digital health. Okay, I still imagine the condition of Indian healthcare system where, when we were training one of the prototype, and I still remember I've given the one of the command to the prototype stating that, okay, the 67-year-old patient with a CVA history of a tracheostomy and all. Believe me, the AI took time to understand what is CVA. That is a cerebrovascular accident. So I strongly believe there is a hallucination case, as you mentioned, and obviously the clinical judgment and the responsibilities cannot be waived off. And when it comes to a technical, or when it comes to an administration, so the operational work, I strongly believe that AI can take over, not the entirely when it comes to the assessment part. Also, very well said, doctor.
And at least not the human touch. That
Yeah,
is,
human touch. Yeah, absolutely therapeutic touch, what we say. Yeah, cool. Okay, so moving on to the resilient of the hospital. What separate a hospital that simply survive a crisis from one of the continues delivering care despite of the crisis? So you might have noticed the hospital crisis, what they survive on and how they deliver it. So is there any example you can actually set in and you can share the information on the workforce, on the infrastructures, and etc.?
yeah, see, any disaster of any form, like the recent COVID infection, or it could be a landslide, multiple cases coming in into a certain geography based on the number of hospitals present. So the hospital must be able to have a opportunity to expand or contract based on the kind of situation that is. And most importantly is the manpower more than the infrastructure. Sometimes what happens is because of the manpower issues, chronic burnout, when there is a actual situation, it will be very difficult to handle it. So I would also look at this, the supply chain, for various things that is required at a crucial disaster or a situation. So there must be a proper command mechanism where instead of creating chaos at that point of time, that is why I mentioned the code mock drills that we all practice very strongly, like code yellow, that means multiple cases coming in at a single time in the hospital, or a code red where there is fire in the hospital, where how you address it similarly. So when it comes to the resilient mechanism, so it begins with the hospital, how they equip the hospital with the resources, manpower resources, supply chain resources, the space which they can expand, add on beds, and also the amount of training that they give to the manpower. So basically, all goes around anticipating that anything could happen and adapt accordingly, so that that only makes the next disaster readiness more stronger.
Yeah,
Of course,
absolutely.
there is, as per the surge capacity, we always have to coordinate with the nearby hospitals, talk to them, and understand what we could do together during a situation which could arise and we are out of capacity.
Yeah, definitely. I'm going to ask you something very important with an overcrowding crisis. Okay, so I'll segregate these questions in the two steps. One is, you worked in Bangalore. Okay, we know the traffic situations, and we know the many other issues, right? Do you believe the our ambulances are well equipped to tackle every emergency when it comes to the stroke or a heart attack or any other emergencies? Number one. Number two, you have been a fellowship in aviation medicine fam from ICAT. Okay. So what do you think? What could be the future in next 5 years when it comes to the high-end technology? Over to you.
Yeah. Uh, the number of hospitals are going to increase. There are micro markets in various geographies. So even the smaller hospitals are getting equipped for immediate emergency care for conditions like stroke, cardiac, trauma, medical illness, or acute bleeding scenarios, or a snake bite, or a fall from height, whatever it could be, poisoning and all that. So the importance of ambulance has already been understood by people. You can see, for example, ambulances being parked in strategic locations. You look at Mars Manipal ambulance response system. We are a huge fleet of ambulances parked in strategic locations all across the city, and it is based on the QR code. Everywhere it is available. So when you scan the QR code and put your location, ambulance reaches there. So that is it. And even recently, we have launched the bike ambulance. Even before a four wheeler reaches in this traffic, the bike will go and do the initial care and arrange the other things in medical. So things are evolving. There has been GPS tracking system. There has been smaller markets with multiple hospitals. more number of specialists coming in, and tier 2 cities are also getting well equipped with consultants. And aviation medicine is going to be the future again, with intercity patient transfer with helipads across the city. It's already happening in Bangalore itself, and in India, across cities and across states. So I think the awareness is increasing. People know that initially we would not know. We would wait to go to a clinic or a hospital by car. Now people at least know to call for an ambulance, but we have a long way to go. And I'm sure with the kind of community trainings that we are doing and lot of doctor connects happening in the community, there'll be a lot of improvement in terms of accessing the emergency care.
Okay, looking forward to have a better prognosis, and that should be the key
Yes.
of any of the hospitals and their state of art of the department. Okay, so there is an important aspect, doctors. In emergency, there is something called a dangerous handover. Okay, so I would use this statement because can a patient survive in the emergency but still can be put at the risk during the transition to the next stage of the care? I'm sure you might have noticed in every situation there are morning, evening, night shift. So,
Yes.
how does it work, and what are the maybe rules and regulations you might have followed in your hospital settings, or have you come across with any kind of a negligence?
When it comes to emergency medicine, the golden rule is whenever any sick patient comes in, any patient comes in, we do triage. And more so when it is a sick patient, we follow the golden rule saying that stabilize, assess, and resuscitate. What I mean to say is you do not treat the patient alone. You evaluate and you treat. That means to say both goes hand in hand. If you're not evaluating, only trying to treat, you might miss out a key diagnosis, right? Like aortic dissection or an heart attack. Okay, if a patient comes with hypotension or a low saturation, you cannot just keep resuscitating with oxygen or fluid or inotropes. You have to assess as well, evaluate. So we use the primary survey adjuncts, and also you treat the patient. So assess and treat. So that is the golden rule. So when it comes to such any critical patient, the handover is given bedside at the end of shift, and in between shifts, suppose a patient has to go to another area like a operating room in case of a ruptured ectopic, or it could be a aortic dissection or a massive pneumohemothorax, or head injury. The doctor from the emergency gives handover at the bedside by shifting the patient to the critical care or to the operating room, giving all the details, how they came, what we did, what we assessed, what is the diagnosis, what is the evidence of diagnosis, and why they've shifted, and who's the doctor they communicated, what they communicated to the patient family, what is documented, and what is pending. So we use the SBAR, situation, background, assessment, and recommendation. So this is global. So this way, we make sure that we give the handover, and also transition from. It's not that every patient has to stay in the ER, get stabilized. If a patient needs immediate stopping of blood in the operating room, we transfuse and shift the patient with all on the bed, the monitors, the ventilator, the infusion pumps, with critical care specialist, emergency specialist, moving patient with the nurse in a very safe way. And if a patient, same similar to cath lab, unstable patient, stabilized to the point of stabilization, but we do not waste time just holding there. If it has to be moved, we move and do what is definitive care, right? Like for example, PCI, or it could be a patient of dissection, or a patient of a polytrauma who's bleeding, who needs interventional radiology to embolize and stop the bleeding. So emergency is well equipped now to take these decisions, and it needs a lot of training and drills as well. It cannot just happen out of the box.
No, definitely, because emergency medicines will teach you not only the leadership, it teaches a lot of things. So, I would like to ask, what is the prognosis of Manipal when it comes to the emergency situations?
So the best part about emergency departments across Manipal is standardization of care. So we have a platform where all of us come together in that platform and discuss cases, discuss important rare cases, discuss protocols, discuss the resuscitation updates. We have the same Mars ambulance across, so that we have a connect across all what we call as inter-unit Manipal synergy. So all Manipal emergencies are connected. The prognosis is very good in terms of timely approach, what I could say, with the geographies having Manipals. Like, for example, we have 15 Manipals in Bangalore, where every geography is having a bigger Manipal, and then state of the art infra and manpower and the treatment protocols. So we always had opportunity to do timely care with a multi-specialty approach in the emergency room, sticking to the right kind of protocols, and making sure we involve the family during the care, not just treating the patient and not giving the right kind of information to the family. So somewhere it has been a great platform in terms of providing the timely emergency care, and we have the huge number of cardiac, stroke, trauma, and multiple medical and surgical cases that present. And when it comes to technology advancement, it is again state of the art, which supports the emergency care, is where the strength lies.
Absolutely. So, as you know that we are LinkedIn, Facebook, Insta, and the YouTube Live. There are many lay people also must be watching this
Sure.
podcast. I would like you to give a couple of conditions and how they have to manage at home. Say, suppose a stroke, heart attack, or any other situations which come across. So, would you mind sharing your insight on quickly basis?
Yeah. The most important thing I would like to request all on this podcast, who can watch now or who can watch later, is please know the basics of first aid, know the basic symptoms of major specialties like cardiac, neurology, or a hypoglycemia, or a hypotension, like a low sugar, low BP, or if somebody is looking toxic because of septic infection in the body, or any bleeding from the nose or from the urine or from vomiting of blood. So there are a lot of such conditions, but primarily the most important conditions are the cardiac chest pain, breathlessness, or also the stroke, where there are classical pre-hospital stroke symptoms like slurring of speech, they're not able to talk clearly, deviation of the face, weakness of the limbs, drowsiness, and things like that. So you will have to get immediate medical care. Chest pain, it is always safe to get medical help. People attribute it to gastric or stress or tension or whatever. It is very important to at least get a screening tool like an ECG, but not to panic, because not every chest pain could be alarming, but it is very important not to miss out a cardiac condition, thinking not every chest pain could be cardiac. So just it's a golden rule. Just get evaluated for chest pain, considering the rise of number of cardiac arrest and heart conditions in the community.
Yeah. Now, even we talk about the burn is also an emergency, right? So, what do you think in the private hospital? How much percentage of the burn cases are expected, and what is the intervention has been carried out?
Burns, there are dedicated burn centers in all cities nowadays. So very severe burns usually we try to not take, because it is a certain care by itself. Burns care is a very highly specialized care, where it is a dedicated burns unit to be there with the trained personnel. But to some extent, doctors do take in cases for minor burns or first degree burns, certain to certain percentage, or even the in a better way to put it, all burns are taken in emergency, initially treated with the cannulation, fluid resuscitation. There is something called Parkland formula. We have to resuscitate the patient, cover the patient adequately before sending to burns unit or admitting in the same hospital, because burns will expose the skin and cause severe water loss, and can cause hypotension. And getting cannulation is very difficult. En route, people can, and then maintenance of airway in severe third degree burns, and also to make sure that pain management is done, and these things are very critical and high priority in any emergency. Then it can be decided what is the further plan with the evaluation.
Absolutely. We spoke about the many more emergencies. However, there is one also important part called the drugs. Okay, you might have experienced couple of the patients who might have using a drugs and they have come to the emergency, or they might have been visiting the primary, secondary, or tertiary care. What would be your intervention in such scenario?
So basically, we kind of see it all goes with the presentation, talk syndromes. It all
Mm,
goes with the history. So
mm,
both come in hand,
mm.
and also there are clinical signs as to what it is, right? When you handling such cases, and there are well set protocols and care pathways to handle, and the doctors are usually trained in what is the toxin syndrome that the patient presents, what is the line of treatment, how to counteract the medicine effect, and also to make sure that the observation, the escalation to the family, what it is, and then authoritative approach. So there is a lot of streamlined procedure for this, which is to be trained. It otherwise could be a deviation.
Yeah, completely understand. So, Doctor, the last question before we have a rapid fire. The future of emergency healthcare in India. If you had given a chance to redesign Indian emergency, okay, and the healthcare system from the ground up to the level at the high level, so what will you begin with?
So, like I told you, the most important thing is about recognizing the department, right? So, rebuilding all revolves around making sure the awareness about emergency care is emphasized in the public, right? So, rebuilding includes, like I told you, not just infrastructure alone, standardizing across institutions the kind of care that goes to the patient, so that people know actually what is the exact kind of line of treatment that goes for conditions. So even now as we speak, people are very educated. They understand what kind of care will they receive from various hospitals. So standardizing that is very important, in par with the global recommendations and guidelines. Number two is the technological advances has to be put in, so that the timely diagnosis, timely interventions are done. And of course, accreditations of all emergencies is standardizing. When you accredit emergency department, so that is based on checklist, right? So you look at a lot of practices that is going into the department. So that itself will standardize. So that has to be made mandate, which is happening right now. And of course, the training aspects will be the most important, and that also has to be standardized. It cannot be different across different institutions. So luckily, when you look at Manipal, that is one thing across all emergencies. The kind of standardization of trainings, standardization of equipment, technology, manpower, and the trained emergency personnel deployed in the ER is standard. So that has to be inculcated in all. So that is redesigning.
Yeah, absolutely. Very well mentioned, because a build to an integrated emergency start from a community, ambulance, emergency department, ICU, and the rehabilitations. Definitely, it will be indeed important to invest in the people, the doctors, nurses, paramedics, technicians, as well as the disaster response team. And definitely, which can create an environment where we have a national digital emergency intelligence healthcare system, which can really enabled in India. Maybe, sooner we should work on that as well. So, moving on to the couple of powerful rapid fire, doctor. Okay, so one word to describe emergency medicines.
A temple of life saving.
Oh wow, that's amazing. And the first thing you notice when you enter an emergency department.
The readiness,
Okay, the most important quality of an emergency doctor.
calm and composed.
Okay, one decision you can never afford to delay.
uh, Timely intervention.
Okay, AI or human intuition, which will shape the future more.
Collaborative.
Okay. Your biggest lesson from working high pressure situations.
take care of yourself, then you can save a lot of lives.
Cool. One myth about emergency medicines you want to break.
Uh, that yeah, this slowed me down. Not all patients going into emergency should survive. It is
Okay.
not possible. Actually, this should go to the geography. People expect, especially, in conditions where the hope is less. You know what I mean?
Yeah, absolutely. I
Sorry, I
completely
dragged your
understand.
rapid question. Go ahead.
Yeah, no worries. A moment that made you proud to be a doctor.
Oh, the feedbacks that people give, especially after a successful outcome, and the feedback that people give when even they lose their loved ones, but they look at the empathy and care that we have given.
Okay. One change India urgently need in emergency healthcare.
Uh, Recognition and standardizing.
Okay. Your personal definition of the golden hour.
It is truly golden, and it has to be the uh, line which has to be known by hearted by every household, that it is really every second counts. It's not hour. It should be golden second.
Okay, cool. So the golden hour is not defined by 60 minutes. It is defined by what we do when time, informations, and the certainty are all running out. So here we sign off with Dr. Mahesh. It's been really indeed pleasure to have you and discuss. There are many more events which is required because emergency is such a vast, okay, which required definitely series of the event, series of the training, rapid responses, and there are many more informations we can absolutely discuss all about. Dr. Mahesh, thank you for taking us inside the world of emergency medicines and sharing such a valuable insight from remarkable journey. Your perspectives and the leadership resilience and the technology that's saving the life when every second matters was truly inspiring. On behalf of JVA Tech Meditations and the Power of Knowing You Forum with the collaborative approach with the MedTech Insight podcast series, I really wanted to extend my heartfelt gratitude for your time, your wisdom, and your meaningful contribution. Thank you once again for being with us and making this podcast and very memorable. Thank you so much for all the participants being here with us. I know it's really important topic. We have discussed so many things and there are much more informations to be needed. But however, stay tuned for the upcoming podcast where we will invite Dr. Sanjay Desai, an renowned vascular and endovascular surgery, and he will be there on the second week. Thank you so much. Thank you so much once again, Dr. Mahesh.
Thank
Signing off.
you. Thank you so much.
Yeah.